Good evening, everyone. My name is Rena Laughlin, and I am the Program Director for the Epilepsy Foundation, Eastern Pennsylvania. We and our friends at it'syourepilepsy.com want to welcome you to our webinar tonight called Drug-Resistant Epilepsy, What You Need to Know About Invasive Diagnostic Testing. We have two wonderful speakers, Dr. Ashwini Sharan and Dr. Christopher Skidmore, to speak with you tonight. But before we get started, I wanted to quickly talk about the EFEPA. We are your local affiliate of the Epilepsy Foundation of America. We serve 18 counties in Eastern Pennsylvania as well as South New Jersey. Our mission is to stop seizures and SUDEP, find a cure, and overcome the challenges created by epilepsy through efforts including education, advocacy, and research to accelerate ideas into therapies. We have some wonderful programs and services that we provide to the epilepsy community. We have our seizure recognition and first aid trainings, where we train law enforcement, first responders, school staff, students, anyone that would like to be trained, we will train them. We have our monthly support groups that are currently virtual. We do advocacy efforts, community and awareness events, educational conferences and webinars, information and referrals, youth and young adult services, retreats, and camps. And our camp is coming up in August, and we have an adult wellness weekend coming up in September. So let's get started with the presentation. I'm going to stop sharing here. Okay, so we have Dr. Ashwini Sharan, who is a neurosurgeon at Thomas Jefferson University. He's also the Vice Chair of Clinical Operations Neurosurgery and Program Director for Residency in Neurological Surgery at Jefferson. And we have Dr. Christopher Skidmore, who is an epileptologist and Associate Professor at Thomas Jefferson University. He is also the Vice Chair for Clinical Affairs for the Department of Neurology and Associate Director of the Neurology Residency Program at Jefferson. At the end, we will do questions and answers, so please feel free to type your questions in the chat and I will present it to our speakers. So Dr. Sharan and Dr. Skidmore, the floor is yours.
Great. Thank you very much for the wonderful introduction. My name is Chris Skidmore, and I'm going to go ahead and get the talk started for us. And then about a third of the way through the talk, switch over to Dr. Sharan. Rena, just confirming you can see my slides?
Yes, we can.
Okay. I do serve as a consultant for NeuroPace Incorporated as well as Eastside Pharmaceuticals, and I limit my amount of consulting work to be below the federal limit. That shouldn't be pertinent for the talk today. So what we want to talk about this evening is talk about epilepsy and drug-resistant epilepsy specifically. We want to talk about the kind of specialized care and quality of life goals that we're trying to focus on when we're taking care of those individuals who are suffering from drug-resistant epilepsy. We want to talk about some advanced diagnostic studies, including describing subdural grid electrodes as well as stereo EEG, and Dr. Sharan will go into that in great detail. And then talk about the importance of the epilepsy monitoring unit, which is really a multidisciplinary space for us to kind of record and monitor seizures, and then talk about what kind of comes next in the treatment plan. And then we'll certainly answer questions at the end. So it's important to remember that the brain is the most complex organ in the body. And obviously I'm biased, I'm a neurologist, but there are billions of cells that we refer to as neurons that are organized together in certain ways to basically do all the wonderful things that we can do as a human, whether it's speaking, whether it's experiencing the pleasure of sight or hearing, whether it's feeling something. All of these things are regulated and controlled by the neurons in our brain. And the neurons are fed a supply of sugar to basically keep on working through our blood supply. And remember that the different parts of the brain control different things. So the frontal lobes might be involved more in critical thinking, and then some of the very back of the frontal lobes is in motor function. And your temporal lobes are involved in memory, and your occipital lobes in vision. And so all of the different functions that we utilize on a daily basis without thinking are in different regions and different parts of the brain. And there's a lot of it that just happens automatically. You don't have to think about breathing. You don't have to think about kind of your blood pressure going up and down. And kind of even the brain controls a lot of the automatic things that happen in our body. And so they control the different functions and communicate with the different parts of the body by sending electrical signals that also use chemicals to transmit signals from one cell to another. And so whether it's, the part of my brain controlling my motor movement to control my thumb movement, or the part of my brain that's telling another part of my brain to speak, that's all sending electrical signals back and forth, being helped with chemical messengers. And epilepsy occurs when there's an abnormal amount of electrical activity that disrupts the normal brain activity. And so when there's an abnormal excessive overplay of electrical activity, this disrupts the normal electrical activity of the brain. And that's when we get the symptoms of a seizure. And obviously there are a whole host of different causes for epilepsy. And epilepsy and seizures is really something that can be diagnosed at any point in life. So from the very young newborns all the way through the very old. It is common that one of the most common time periods to develop epilepsy is before age 20. But now in the United States, one of the most common time periods is actually after age 60. And so what causes epilepsy when you're young is a little bit different than what causes epilepsy when you're older, right? So when you're younger, it might have been an injury that happened either during delivery or shortly thereafter. It could be a birth defect that could be on the brain. There might be a genetic abnormality that comes to light. Head trauma obviously can happen at any point in life. You can have brain infections. You can have brain abnormalities, either due to abnormalities in the way the brain processes chemicals, or brain tumors, strokes. And despite all of these things that we know can cause epilepsy, still, at least on the adult world, half of the people that we diagnose with adult onset epilepsy, unfortunately, the cause is unknown. And so there's a whole host of various causes for the treatment of seizures. For the cause of seizures and epilepsy. Epilepsy is super common, right? So in the United States, there are roughly 3.4 million people in the United States with epilepsy. There's 150,000 new cases per year that are diagnosed every year in the United States. And there's approximately 65 million people around the world that are suffering from epilepsy. Now, of that 3.4 million people in the United States with epilepsy, roughly 1/3, 1 out of every 3, have drug-resistant epilepsy. So there's approximately 1 million people in the United States that are living with drug-resistant epilepsy. As I already mentioned, epilepsy is a very common disorder. And so in the United States, it affects about 470,000 children, roughly 3 million adults. As far as in the children with epilepsy, about 20% of them are taking epilepsy medications, and they continue to have seizures. So 1 out of every 5 children continue to have seizures despite medication, whereas upwards of 1 out of every 3 adults continues to have seizures. So the roughly 33% of individuals continue to have seizures as adults if you continue to monitor them over time. So what is our role then in kind of helping to care for individuals that are living with epilepsy? Well, you need a clinician to carefully evaluate the condition, to choose the right medicine, and to hopefully pick a dose that you're going to be able to tolerate and live, hopefully, seizure-free, right? So we want you to be seizure-free and not having side effects. That's the ideal, and that's what we're going for. And the overwhelming majority of people with epilepsy, we are treating with anti-epileptic medication, which some people also call anti-seizure medication. But as we've already mentioned, some medications may not work for some individuals. And over time, some people may go from being controlled to then being not controlled over time. And so here's a definition from the International League Against Epilepsy. So this is a worldwide organization with doctors and scientists and even some lay people getting together to figure out how can we treat epilepsy worldwide. And so they define drug-resistant epilepsy as drug-resistant epilepsy occurs when a person has failed to become and stay seizure-free with adequate trials of 2 anti-seizure medications. These seizure medications must have been chosen appropriately for the person's seizure type, tolerated by the person, and tried alone or together with another medication. So if we then look at this definition, if you are on your 4th seizure medicine and you are still having seizures, you would meet the definition of drug-resistant epilepsy. Drug-resistant epilepsy can be called a whole host of things. It can be called uncontrolled epilepsy. You might hear the word pharmacoresistant epilepsy. You might hear refractory epilepsy or medically refractory epilepsy. All of these words mean the same thing. It means that the medicine is not doing its job and it's not making you seizure free. Now, seizure freedom should always be our goal, because we know if you are seizure free, that your quality of life becomes normalized, meaning it's what we would expect for somebody of your age. We know that your risk of having a major injury from a seizure or potentially dying from a seizure is removed. We know that individuals who are controlled are more likely to be able to get back to work and school and be successful, but not only professionally, but also in their personal lives. And obviously, when you continue to have seizures, it's not that you can't be successful, it's just that it becomes more challenging. And so our goal needs to be seizure freedom. We mentioned this already. So from well-done studies, originally in the late kind of 1990s, early 2000s, and then repeated now with the modern medications, when you see a physician, if they appropriately choose the first medication, half of people become completely seizure-free and are tolerating the medication. If you then move on down here to that second medication, so for some reason you didn't respond to this first one, either you had more seizures or you couldn't tolerate it, another 13% of individuals become seizure-free and are tolerating the medication. And by the time you get to the third medication, you have only a 4% chance of becoming seizure-free. And so that's why the operational definition of drug-resistant epilepsy is somebody who's failed 2, but certainly by your third medication. So by the time you have failed your third medication, the chances of you developing long-term seizure control on the 4th, the 5th, the 10th, the 12th, whatever number of medicine you're on, the success of that is less than 5% chance. And this is where we get that 1 in 3 individuals with epilepsy are not controlled on medication. So individuals who are not responding to medical therapy should be seen by a trained epilepsy specialist, which is what I am, and we're known as epileptologists. So we're neurologists who have gone on to get extra training in just providing care to epilepsy patients. And most epileptologists, not all, but most epileptologists work at an epilepsy center. And many of these epilepsy centers are located in your larger academic and community hospitals. And the reason you want to try to go to an epilepsy center is it's not just the epileptologist, but you might need the care of a neurosurgeon that you work with, like Dr. Sharan, or you might need to see a neuropsychologist or have your images looked at by a neuroradiologist. So when you go to an epilepsy center, the level of care that you're able to get in a coordinated fashion goes up dramatically. And so all of these different providers can then contribute to your care to try to make sure you're getting the most optimal care for you. And the goal with this kind of individualized treatment is really to optimize your outcome. And by optimizing outcome, ultimately what we're talking about is making sure you're having the quality of life, the best quality of life that you possibly can have. And as I already mentioned, we know when we can control the seizures or get rid of the most disabling seizures, we know we can dramatically improve your quality of life, which is at the end of the day, the goal. So when we talk about testing, right? So if you're on seizure medicines and not responding, the first thing that I need to do is go back and take a history again and really make sure, do you have epilepsy? I mean, that's literally the first thing that I need to do is take the history and understand, is this epilepsy or did we make a mistake and maybe diagnose you with the wrong condition? So we want to take a detailed medical history. We want to understand what's going on with your seizures. So you need to bring notes to your doctor's visit of kind of what you remember during a seizure and what other people see during a seizure. We want to understand how often they happen. Are you injured with them? Are there certain triggers that may cause seizures? And all that will help us understand. Next, we'll do a neurological exam. And the reason we do a neurological exam, most people with epilepsy have normal exams, but if it's abnormal, it might give us a clue as to what part of the brain might not be working properly. And that might then give us an area to focus on when we're doing the EEG testing and the MRI. So the EEG stands for electroencephalogram. So as we talked about earlier, our brains are supercomputers generating an electrical signal. So we can measure that with EEG. And when we combine that with video that's time locked to the EEG, I can see exactly what you're doing on the video and listen to what you're doing, and then see exactly what your brainwaves are doing at that exact moment. And so that allows us to record what's happening between seizures, but specifically with video EEG, hopefully we can actually capture a seizure, so I can actually see what you do during a seizure and what your brainwaves are doing during that seizure. We're going to obtain an MRI of the brain to look at the structure of the brain, because again, we want to understand what's potentially causing your epilepsy. Now, again, half of adults have a normal MRI, but we're looking to see, is there a stroke or a brain trauma or evidence of a prior infection that may be causing your epilepsy? And the last mandatory test is neuropsychological testing. So neuropsychological testing is kind of like an IQ test, but with more stuff. So we're going to test how your brain thinks. We're going to test how you process information, how your memory works. But we're also going to understand how you are living with the epilepsy and understand the emotional aspects of dealing with the epilepsy. So we're going to screen you for depression and for anxiety, other things that we can kind of treat to, again, improve your overall quality of life. So if we look at this, the goal of specialized care in an epilepsy center is that you come to see an epilepsy specialist like myself. Again, I do this kind of basic testing that we already just discussed. And then based on that, we decide, do you need additional testing? Do you need to get a SPECT scan, which looks at blood flow? Do you need to get a PET scan, which we usually do FDG PET scans, which looks at how your brain uses sugar? Because remember, I said earlier that sugar is the powerhouse that keeps the brain moving. We might do magnetoencephalography, which is abbreviated MEG. So when our brains generate an electrical signal, it also generates a magnetic signal that we have technology that we can record from. We might do a WADA test, which is an invasive test to look at memory and language function, or we might do a functional MRI, which is now a different type of MRI where we can now test your memory and language function while you're in the scanner and understand what part of the brains it's coming from. And so based on that initial basic evaluation, we decide if these additional tests are necessary. And then we present your case at a surgical conference. And at that surgical conference is the whole group of individuals from our center that participate in the care. So it's all the epilepsy doctors like myself, all the surgeons, the neurosurgeons that we work with, which currently we work with 2 here at Jefferson. It's the neuroradiologist, the neuropsychologist, and everyone is kind of explaining and reviewing their part of your case as a group. And at the end of that, then we decide, do we have enough information? Is this somebody that we can help with surgery? Or is this somebody where we need to get more information and perhaps move into what's called invasive monitoring with subdural strips? That's what STG stands for, subdural grids or strips, or stereo EEG. And again, you might be in and out of the EMU because when you get this invasive testing, that's done in the EMU, but also this non-invasive video EEG is also done in the EMU. So at this point, I'm happy to turn it over to Dr. Sharan.
Okay, thank you, Chris. And I'll take over the screen. Okay, everybody, I'm hoping can see my screen.
Yep, we're good.
Yes.
So here are my disclaimers. I do have 2 particular things that are relevant for epilepsy, cerebral therapeutics, and neurotargeting, but none of them are pertinent to this talk. So I'll proceed. So what Dr. Skidmore really did is, set it up so that hopefully you understand the complexity of the thinking and the sort of this multidisciplinary approach we have, because there's so many variables that we have to consider when we're trying to figure out your brain. And what I'm particularly going to talk about now are the invasive tests. Now, this part of the talk, just to be clear, is for patients who are resistant to the medications. So, if your epileptologist or neurologist cannot stop your seizures or control your seizures, this is how we start thinking about epilepsy. And so basically, the non-invasive tests aren't helpful enough to help the neurologist control your seizures. And of course, sometimes people are resistant to medications or have side effects that don't allow them to tolerate drug after drug after drug. And so that's when we start thinking, can we identify where the seizures come from? So, for example, location is everything in life. Location in your brain where the seizure might be coming from is very critical. And so we meet together as a group, and the hope is that if we can understand your epilepsy um, from a brain perspective, think of this as a big circuit board with many nodes or many types of chips. If we can figure out where the malfunctions are or how that network is connected, then we might be able to offer some type of surgery to safely treat your epilepsy. And so there are two types of tests. And basically, if you want to think of it broadly, I think everybody on this call probably has had surface EEG electrodes placed, and think of them as antennas that are picking up electrical signal. And for the surface electrode to pick up the epilepsy, a large portion of your brain has to be seizing. Now, we get so much more fidelity, you get better signal to noise if you actually put the electrodes on the brain or in the brain itself. And if you want to understand the rationale behind it, think of the hair, the skin, the skull, and they're insulating the signals. So you don't get the full resolution on the signals. And so there are two types of electrodes that we can implant underneath or inside the skull. And I think Dr. Skidmore mentioned them. We call them subdural grid electrodes and stereo EEG electrodes, and I'm going to go through both. But basically, they will record the activity of the brain. And today, all this modern type of surgery is done with a lot of navigation technologies, and I can answer them in the question part as well. So we meet together as a group. We study all the tests that Dr. Skidmore talked about, the EEG, the MRI, the PET scan, the videos that you've had, which have looked at the patterns of your epilepsy. We consider your psychology and the neuropsychological profile and how it's affected your brain. And we look at, what are the indications to do surgery? What are the contraindications? Can we safely do surgery? And the conference also includes a radiologist, and effectively we spend 30 to 45 minutes with about 6 to 10 people with a lot of experience, really drilling down into, can we actually find where your epilepsy is starting from inside the brain? And so first I'll tell you about the strip and grid electrodes. So just if you wanted to give a visual, it's a strip. Each one of these circles would be a contact, which would record on the brain, and a grid would basically be a ray that would sit on the brain. And so basically strips are in columns and grids are in rows and columns. And they're actually very helpful. And the majority of the centers, I think, in the United States are still doing grids and strips. In fact, we used to do almost all grids and strips I've been an epilepsy surgeon now for about 20 years. And so for the first 15 years of my career, this was the best technology that we had. And I don't want to tell you that stereo EEG is better, but there are some advantages to one technology versus the other. And I think we've made a shift to the stereo EEG technology. So the grid electrodes are placed in the operating room, as are the stereo EEG electrodes. And you have to have general anesthesia. And typically we have to remove or really cut short the hair and the scalp, because there's going to be many wires from the grids and strips that will have to be connected. So to put a strip in, you have to make a small hole and you slide these strips on the surface of the brain where we think is the highest point we're going to find your seizure. And to put a grid in, you can imagine, because of its size, I'll go back for a second, you have to actually open the skull in a larger piece so you can actually lay the grid inside the brain. And then of course these wires come through the skin. And after the operation is done, the head is wrapped up and those wires will be connected to the EEG monitoring equipment inside the EMU, the seizure unit. After surgery, most centers will get some kind of CAT scan or MRI, really to figure out, where the relationship of the electrodes, were they placed exactly where the team wanted it. and then you will stay inside the EMU and you'll be there until you have enough seizures so we can understand the pattern of your epilepsy and the generator. The other type of electrodes or invasive monitoring that we have is what's called stereo encephalography. And so much more complicated, much easier to basically say SEEG. These electrodes, just to give you a sense, they're almost as thin as spaghetti. They're 0.8 millimeters, and they can record both superficial and deep structures. So that's the difference really between grids and strips and the stereo. The stereo allows you to go within the crevices of the brain, whereas the grids and strip really just basically record the surface. So I think you can get a lot more information from stereo EEG, and arguably it's a little bit less invasive. So to give you a sense, these stereo EEG wires are much more thinner, and so you just to insert them, we have to do what's called a twist drill. So same type of surgery is done in the operating room. You have general anesthesia. You have to clip the hair, and then you can see this is what it would look like inside the skull. Just little wires that go through the skull, and most institutions will use some kind of halo navigation and or robot or all of the above to place these electrodes, because you need to place them really precisely into the target that you're thinking. And because of the three-dimensional nature, there's a big strategy involved in terms of how to implant them. And if you look at this cartoon here, this is an MRI of the brain, and you can see the color represents different electrodes inside the brain. These aren't as big of a hole. Each hole is literally 3 millimeters, and there's something called an anchor bolt that actually holds the wire in place. And we actually have to open the surface of the brain in both scenarios, both for the grids and the stereo. And then these anchor bolts hold it into place. And then, of course, your head is wrapped up in a Band-Aid. And the next day, you're typically transferred to the seizure monitoring unit, the EMU. And again, with this technique also, most centers will get CAT scans, MRIs, because we want to know that the electrodes are where we wanted them to be. Now, the average length of stay once you're in the seizure unit can be anywhere from 10 to 14 days. And it really depends on, or even longer, and it depends on how long it's taking to have your seizures. And I'll talk about that in a second. So a couple of things, both are very safe procedures. Both actually help to give accurate diagnosis. There's a lot of precision and technology that goes into placing both. And basically, they can help you determine what might be the next form of treatment. And the healthcare team will discuss that. Now, I'd be remiss if I didn't tell you that these are both surgeries. They both carry risks of bleeding, infection, neurological side effects, depending on if the electrode is in the intended target or not. You can have consequences of that. So in most experienced centers' hands, the risks of these operations are under 5%, and most centers nowadays are probably carrying a 1% infection and neurological consequence and bleeding problem. But I think you want to ask about the experience of the center before you embark on that journey. And you also want to know how good the team is about working together. In our center, we've been doing grid, strip, stereo EEG, or the combination thereof, for over 20 years. Even before I was the surgeon, we had a surgeon doing it at Jefferson much longer than that. So the next phase of your journey is actually in the seizure monitoring unit. So most centers will keep their patients overnight in the ICU, really, for observation. And then you're actually transferred to the specialized unit, and perhaps many people are familiar with this. And a whole team is actually involved in your care there. And slowly, it's typical, not right away, but because most patients who are being implanted with these invasive diagnostics are having seizures despite medications. And so we typically give a few days, let the person catch up, get over the anesthesia, get over some of the surgical issues. And then sometimes we actually reduce your medications inside the seizure unit. Now that can be really scary because you know that the seizures are trying to control your epilepsy and preventing things from getting worse. But at this time, you're in a very controlled unit with very experienced nurses, very experienced technicians, and a big staff of physicians who are watching you. And the idea is that we're trying to study your epilepsy. The team is huge, and I think I mentioned many of these. Most of the large centers where seizure units are also have residents and fellows. They have social workers, and this is on top of the epileptologists, the psychologists, the nurses, and the technicians. And so it's a big unit of people who are really there to make sure that you get the care that you need. Um, I think I touched upon some of these issues. And so the length of stay can be long inside the seizure unit, and it really depends on how well controlled or unwell controlled your epilepsy is and how your brain reacts. Before I prep somebody for invasive monitoring, I did state, and it's accurate, that the average length of stay is 10 to 14 days. But sometimes you have outliers who can be there longer. And to prepare for your stay in the seizure monitoring unit, epilepsy monitoring unit, you want to bring some books, you want to bring a lot of Netflix movies and accounts or games, and keep yourself busy. Because once the wires are there, you go through so much effort to do surgery to actually place them. Um, we need to really figure out what's happening. And so a couple of recommendations, really, bring comfortable clothing. Hospital gowns are not fun to wear and probably have an excessive amount of aeration. You can bring button down shirts and sweatpants, bring books and games, bring extension cords to charge your electronic devices as well. Most hospitals carry most medications, but if you have some non-generics, sometimes that can be an issue, and it's worth exploring as well. Most of the time, you're going to have a private room. Most of the time, we even have family members who stay with the patient with epilepsy, and that maybe had a little bump during the COVID era, but I think things are probably normal now. You will have an electrode cable connected to your head, and you're wearing a box on your body, and you can hang that on a pole. They do give you some ability to move around, but basically we need to be able to grab those electrical signals and send it into our monitoring system. And there's also videos and microphones, because we're not only studying the electrical activities, we're trying to also study the behavior changes that come with your epilepsy, because that gives us a lot of clues about what parts of the brain are causing those different types of behavior. So that's a very key thing. Of course, there's no video recordings in the bathroom for your privacy. In the seizure unit, your vitals are being checked regularly. It is a hospital, so any tests you need can easily be done. Your surgical wounds are assessed and cleaned daily. Medicines can be given by mouth or IV. And like I mentioned in the beginning, your seizure medicines get tapered slowly, because we want to promote that hyperactivity of those electrical signals in your brain, so we can catch them. And every day we're looking at those electrical signals, and the epileptologists and the teams are monitoring them, and we update you when we start seeing the changes. And of course, a lot of people have auras, and there's a button you can also click, and so you can also tag. This way we're also informed if you find a change before we see it. We'd like to know that as well. So what happens is, after the length of stay, the most teams like to have anywhere from 3 to 5 seizures. We're hoping that the pattern is the same over and over again. I think that usually is a better prognosis. And then we try to determine what should be the next course of action. And again, that requires typically a multidisciplinary meeting. The neurologists and neurosurgeons, we get together as a group again, and we talk about, should we do this? Should we try to go for removal of the epileptic tissue? Should we try, is it in an area of your brain that can be safely reached? Is it an area of your brain that could be reached with some of the new technologies today, like laser ablation? Is your epilepsy coming from an area that cannot be removed because it's called eloquent brain, parts of your brain that are critically important? And so then do you consider doing something like a defibrillator, which is something called an RNS device, or a DBS device alternatively, or a VNS device? So there are many options. The epilepsy unit team will discuss those options with you, depending on which way you choose to proceed. Sometimes that second operation can be done in the same hospital stay. Sometimes it's actually staged. So that decision tree is quite complicated. Um, and then more than likely, so two separate pathways. I talked about two types of electrodes. Grid electrodes, you have to go back to the operating room to take the grid out. The stereo EEG electrode, they really come out right by the bedside, which sounds weird, but it's really like a string that you pull and it comes right out. So the team will go through that with you. We'll sit down usually with you, your family. We usually have to spend 45 minutes to an hour and sometimes more. And sometimes you go home and you have more questions and you come back with it and it gives you some time to think. And we go through it as many times as you want. And epilepsy centers are very rigorous about this because you're making then of like Dr. Skidmore said in the beginning of the talk, the brain is one of the most complicated, if not the most complicated organ there is, and it's such an important issue. And so we spend a lot of time going through the case and making the recommendation, and that could be different types of surgeries. And I'm not going to get into every type of surgery with this talk, or do you tailor your medications? Is surgery too complicated? So any one of those things can be there, and of course, there's always other options too. There's, I think a lot of people are hearing about the medical uses for the cannabinoids, ketogenic diet, yoga, mindfulness. So there's always something in the pipeline, and a center that can do invasive electrode monitoring can also truly prep you on any of these other therapies and options as well. So I'll stop there and perhaps open it up for question and answers.
Okay, wonderful. So we do have some questions that have come through. Our first question here, let's see. Okay. Are the neurological side effects long-term or just present as an immediate risk? So I think this was referring to when you do like the brain surgery for monitoring.
Yeah, so they could be either or. It's a loaded question. It's as long as the electrodes don't cause injury to the brain, then by and large, the side effects are very short term. Sometimes the brain reacts and can have some swelling, and we give steroids, and most of those side effects really disappear.
Okay, thank you. Another question, how do you close the skull flap after the craniotomy?
As long as you don't try it at home. The skull bone is the best way I explain this to patients is everybody's seen a chicken leg, and when you crack it, there's bone marrow inside. The bone marrow is what allows the skull to grow. Bone to grow, sorry. The skull has no bone marrow, and so it cannot ever grow back. So once you cut the skull bone, it can never mend itself. And so we use tiny titanium plates to hold it together, and they're incredibly strong.
Okay, thank you. If anybody has questions, please put it in the chat. Someone did ask if you were going to speak about the DBS, and I did message them to see if anything in specifically, but do you want to say a few words about DBS?
Yeah, glad to. So deep brain stimulation is a technology now that's been around. It was FDA approved for tremor in 1997, and then it was FDA approved for Parkinson's in 2001, and then I think for dystonia in 2005, and it was just recently approved for epilepsy in 2018 or 2019, towards the end of the year. And basically, it's a little bit thicker of a wire than I showed for the stereo EEG. The wire is 1.2 millimeters, and you put two wires in a region of the brain called the thalamus. So the best way to think about the thalamus, it's a place in the center of your brain, which is like Grand Central Station. All the circuits connected to the thalamus. And so there's some targets inside the thalamus. FDA approval was done for one target called anterior nucleus, AN. So we try to put the electrodes in the right and left, AN. The wires are then surgically brought underneath the skin and connected to a battery. that sits in the chest underneath the skin again. And basically, it's a pacemaker that's driving electrical signals to this area of the brain called the thalamus. So in general, it's not a curative approach to epilepsy. It has the ability to decrease seizures. It has ability to probably also reduce the severity of seizures. And the effectiveness is probably around 50% reduction. Some studies have shown a little bit more, some studies have shown a little bit less. And I'd be glad to take other questions on it if the person has more questions.
Okay, thank you. Another question here. Who decides for surgery and change in medications? The epileptologist?
Well, I mean, it's really a team-based approach. But yes, I mean, your epilepsy doctor usually is the one that's kind of initiating that conversation to say, hey, look, what we're doing is not working. I think we need to look at alternatives. And that's literally the first conversation. I described that workup up until what Dr. Sharan talked about with the invasive implant. You know, that's more of a kind of a fact-finding mission, a discovery mission, right? So we want to discover as much as we can about your epilepsy because you're not responding to medicines, to figure out what the options are. But then at the point that we then sit down and talk, it's really the whole team, but obviously the surgeon and the epilepsy doctor are the two main components of that team.
Thank you. Another question. What are the positive and negative outcomes if you are considering a second surgery after having one already and seizures are still uncontrollable?
You want to do that, or you want me?
Let's both do it. I think there's multiple aspects of this
Okay.
question.
Yeah, so I mean, you know, if we take, there are many individuals that have surgery and unfortunately, they may go on to continue to have seizures. So if we take the best example, so in the best example for the best patient is where everything is pointing to one spot, and that spot is in a really safe area, well away from anything that's critical. In that scenario, the success rate of surgery at 1 year could be as high as 80% of the people, 8 out of 10 people, completely seizure-free, right? But it's not 10 out of 10. So we do know there are some individuals who end up having end up having surgery who might continue to have seizures. However, in those 2 out of 10 people, the majority of those individuals then also see a reduction in seizures. And so we actually help alleviate some of the severity of the seizures. Very rarely, very, very rarely do we make somebody worse with epilepsy surgery. So I think first off, we want to assess why did you fail from the first surgery? And we're going to go back and we're actually going to look back at all the old data with, you know, now knowing that you failed the surgery and say, what did we miss? That's the first thing we're going to go back and look and see, did we miss something? We might repeat the EEG testing, you know, to see, are the seizures still coming from a similar location or are they coming from a different spot? Because in some individuals, the seizure can maybe start in one spot and we operate in that location, but then the seizures might pop up in another spot later on in the brain in a different location. And so can you have surgery again? Absolutely, as long as it's thought out in a very careful way. And what we're often looking for is, are the seizures coming from an area near where that original surgery was? In general, we typically don't, if you had a surgery on the left side, we typically don't operate on the right side then. So that's where we might start talking about neurostimulation, although that's not an absolute. So that's at least my thought.
And a couple of things I'll add to that is the reason or the rationale for a second surgery really should start, and depending on how severe are your current seizures, you know, and so the word uncontrollable, you know, would probably need to be clarified and its impact. And I think Dr. Skidmore really also touched about is how safely can we actually get to it, and sometimes what has been studied and understood is, like patients who we had implanted with grids, we are now doing stereo EEG for, because the technology changed where we could only really record the surface, and now we can record in the brain as well. And so we were able to see more than we did back then. So I think there are a lot of nuances to that question. And so I think the technology, as long as technology keeps getting better and it remains safe and the probability of harm is low, then second surgery can be considered. And you always want to keep abreast on that, because I'll tell you that in my 20 careers of epilepsy surgery so far, it has technology, MRI technology has changed, robotic technology has changed, the electro technology has changed. Our ability to even get at deep structures with the laser ablation tools has changed. And so there's always something else that might happen. But to put it in perspective, if I've done over 1,000 epilepsy surgeries, I think less than 100 were second time surgeries. So they're not common.
That's because most people respond.
Yeah.
Right.
Good point.
Okay, great. Thank you. Another question, is there a general consensus as to when you start the process? Is it after 2 or 3 failed medications? And then that kind of falls into another person had a question, if medications don't work, is that considered drug-resistant epilepsy?
Yeah, so I mean, at least in our center, in our practice, after your second medication and it's failing, we're going to start talking about the fact that this might be drug-resistant epilepsy and start to think about, what kind of pathway we are on. And this is the first time I might sit down and talk in depth about, there are other options other than medication. And, do you want to start to explore those options now to kind of start that conversation? Because it can be, as a medical doctor, when I mention, oh, by the way, maybe we need to do brain surgery. By the way, I've never met a single person that doesn't go, what are you talking about? There's always that kind of pause, which there should be, because we need to take this seriously. But yeah, it's right around 2 medicines. Certainly by the 3rd medicine, you're clearly defined as being drug-resistant epilepsy. Again, appropriately chosen medications at the right dose. If you have side effects on very low doses of 5 medicines, and never get to a high enough dose to see if your seizure are going to respond, that's not drug-resistant epilepsy. So you have to be on a high enough dose of the medicine that we know that treats epilepsy for most people, and be on it for long enough to know that you had a seizure on that medication. So once you've had 2 medication trials like that, that's when we define it as drug-resistant epilepsy.
Perfect, thank you. Someone wrote that if they are very anxious before the EMU stay, can they take medication for their anxiety? And is there anyone they could speak to while in the EMU if they have a panic attack?
Yeah, so every epilepsy monitoring unit does this a little bit differently. Our epilepsy monitoring unit, the neuropsychologists are actually integrated into your stay. So when you come into the epilepsy monitoring unit, you actually meet and go and sit down with the neuropsychologist and do your neuropsychological testing, ideally when you're in the hospital. What's nice about that is, exactly as you asked, it allows the neuropsychologist to meet and understand if there's something going on. And if you are feeling nervous and anxious, the medical doctors can then give you medication to maybe help treat that, or maybe the neuropsychologist can just talk you through some of that information. The IQ testing, the neuropsychological testing itself takes sometimes up to 6 hours to do. So it's nice to be able to do that in the hospital, because you can do it on one day for a 3-hour chunk of time and then do it on another day for a 3-hour chunk of time. So it also helps kind of kill some of the time while you're here in the hospital.
Thank you. Okay, what is your idea about FCD patient with drug-resistant epilepsy in terms of using ECOG or SEEG? And then there was another part to that. What is your idea for thermocoagulation RF in these patients?
Yeah, so let me just clarify the
Okay.
FCD for everybody listening is focal cortical dysplasia. And so it's basically a tangle of neurons, which can cause the epilepsy, and there are different types also. Most of the time, sometimes they can be on the surface, they can also be deep. If they are on the surface, then you can easily map it out with a grid or strip electrodes like we showed you. If they're deep, you have to consider doing stereo EEG. So it really depends on the anatomical location of the FCD. And the second part of the question, which the person is asking is how do you treat it? Can you treat it without surgically opening up the brain or skull to get there? And there are two technologies. So there is something called LITT, which is a laser tool, which you can put inside the dysplasia or inside the brain. And inside the MRI suite, you can activate the laser. And with really high precision, you can remove lesions in the brain, spots in the brain that are almost 16 millimeters wide. So that's about the width of that. Now, for focal cortical dysplasias that are smaller, people are using, mainly in Europe and a handful of centers in the United States, what's called radio frequency thermocoagulation. So they actually heat the actual electrodes and by energy. And the idea is, can you remove the tissue just by the heat? Now, just to be clear, that is a technology that is still in development. There are tools in Europe that already exist regarding radiofrequency thermocoagulation that allows you to get the feedback to see how much heat you're sending inside the brain. And the real data on how effective it is not determined yet, because the number of cases worldwide reported with radiofrequency thermocoagulation is quite small. And so people are treating many different types of epilepsy, so it's not considered a mainstay treatment.
Wonderful, thank you. Another question, do I have to shave my hair for invasive tests? Are there other options?
In our center, we definitely shave the hair. It makes the operation definitely easier, and it's easier to keep the wires sterile, clean, and prevent infection. But clearly, it's a traumatic thing to shave your hair. And so it depends on really how thick your hair is. And if you have thinnish hair, there are centers who really just use aggressive shampoo the night before and in the operating room and try to preserve the hair. So there are centers also that would consider it. And mainly in the pediatric population, the hair is usually smaller and thinner as well. And a lot of centers will not shave.
Thank you. I think that's it. If anybody has any last minute questions, please put it in the chat right now. All right, well, I want to thank our knowledgeable doctors tonight. Thank you, Dr. Sharan and Dr. Skidmore. Thank you to our viewers for spending some of your evening with us tonight. Special thanks to our friends at it'syourepilepsy.com. Just going to quickly share my screen to show how to stay connected to the foundation. Okay, so to know more about our resources and our upcoming events, you can visit our website at www.efepa.org. You can follow us on Facebook at Epilepsy Foundation Eastern PA. We have our Instagram. You can email us at efepa@efepa.org. You can give us a call at our office, 215-629-5003. Thank you so much, everybody, and have a wonderful night.
No, thank you for hosting also, Rena.
Thank you very much.
Thank you.
Thanks, everyone. Good night.
Good night.